I'm sorry I couldn't be with you. I had promised Dr. Carper I would be at the panel, but I inadvertently scheduled additional meetings at the same time. So I wanted to share with you a little bit of the information you'll get more of over the next few semesters related to the algorithm. So a couple weeks ago, I presented evaluation and treatment of scapular dyskinesis at Philadelphia at the National Athletic Trainers Association. And this slide, I believe, was one of the pictures that Dr. Carper had shared. So I use this in my presentation, but I actually treat patients with this scapular rehab algorithm. And I teach you in 650, but it's somewhat in 652, a little bit about the assessment and management. So I don't have time to do the whole talk, nor do that would take up your whole class. But I wanted to go through this sort of step by step. So Todd Ellenbecker and Ann Cools are physical therapists that deal with a lot of shoulder problems. Ann is a famous physical therapist in Europe. Todd Ellenbecker is a famous physical therapist in America who takes care of a lot of, they both have a very mutual love for tennis and overhead athletes. So if you look at this algorithm, this is basically sort of giving you a game plan of how to manage different problems. So one column, the left column is soft tissue, the right column is more muscle performance. So when I talked in the presentation, I talked about managing these different problems. So if I find a mobility deficit, I tend to treat that first. I work with mobility exercises, which I'll show in a second. If I have core problems and shoulder problems, then depending on where they are, if it's an acute shoulder injury and I have to immobilize them, like a fracture or dislocation, I can still do core exercises to help them recover. If it's an athlete and maybe they just have a really inflamed or irritated shoulder, I might do some modality interventions, but at the same time, I'm starting to work on their trunk, maybe doing some scapula stuff, looking at their hip, especially if they had deficits that I found during the evaluation. And then scapular dyskinesis is an impairment of a motor control, motor dysfunction, or tightness issue causing the scapula to not move normally. So I try to integrate that. So I'm going to skip the dosing principles and just talk about this picture. So this, I've sort of blocked out the right side. And so you can see that we have scapular muscles that get tight, like the pec, the levator, and the rhomboids. Not all of those are rotator cuff muscles, but we do have glenohumeral muscles or scapulohumeral muscles, like the infraspinatus, like the subscapularis that can get tight. And then what we want to do is use many different techniques for manual stretching, home exercises, soft tissue techniques, mobilizations to help facilitate relief of those symptoms. So this is a busy slide, but if you sort of take it one row at a time, at the top, you'll sort of see anterior tightness. So that's going to be pecs, pec minor, subscapularis, and what things I would teach them to do at home in a gradual progression from simply laying down and stretching their shoulders to a bilateral double arm doorway stretch. Some people just can't tolerate that initially. And then in the clinic, techniques that I might use, such as soft tissue releases, contract, relax. I incorporate some trunk motions, things that I can modify. Then as you look sort of going down, things to do for the back of the shoulder, things to do with the cervical and thoracic, which often are incorporated into shoulder rehabilitation. They sort of, the sections of the body have to be looked at together. They're interdependent on each other. And then inferior shoulder, more lats, or teres major, those soft tissues that can get tight. And then these are just examples of different stretching techniques you can see in bilateral or single arm. Over here on the left-hand side, you can sort of see the supine towel roll. That's a nice stretching foam roller up underneath to help work on cervical extension. Pectoralis major, pectoralis minor gets stretched this way. This is to get the biceps. And here is a dynamic exercise where they actively are retracting their shoulder, actively retracting their shoulder blades, not over a foam roller, but just on a table to get stretching of the front and actually strengthening of the posterior. These are some modifications of posterior stretching tissues. I like blocking the scapula when I can, but some people don't need that. They're so tight, they're getting a good stretch. Here's some ways that we can block the scapula manually with a technique called crossbody horizontal adduction. These are all variations of what is called a sleeper stretch. This is the most common picture, but you can drop it down or you can add toweling to cause some more horizontal adduction. Cervical mobility exercises in all the different planes, keeping the chin retracted. And then this would be a stretch for the inferior tissues. Notice that they're all in a flexed posture. So we're trying to tighten up the lats on the most inferior component. And notice that their hands are externally rotated. Remember, the lats are internal rotators. So here, Tony is doing a passive stretch. Here, I've tried to ask him to do it actively, but notice his heels are pretty close to his bottom, but here they are not. Sorry about the black pad in the back. That's one of our former athletic training students. And then here, if somebody can't get on their knees, might be a modification of that same stretch. Scapular mobility techniques, mobilization integrations that we can use PNF and other mobility techniques. So now on the left-hand side is muscle performance. And this is a whole big amount of exercises and stuff. So I'm not going to go through all of these, but most of these are going to focus on motor control and integrating the kinetic chain, the core, and scapular rehabilitation. So this is a very hands-on, a very focused neuromuscular control exercise program. Not so much to build strength. You can get to strengthening, but a lot of it is neuromuscular coordination. Oh, sorry, I forgot about the hip program that I added into there. But these are my principles of scapular rehab: conscious control, exaggeration of movement, and from a poor position that they tend to be in, out of that. And I incorporate them, overemphasizing their poor position to teach them what I want them to get into. Short to longer levers because of loads. Patient with cuff tend to do well when we can get the scapula in external rotation and posterior tilt. Patients with unstable shoulder, I found this in one of your classmates, Elise, tend to do better if we can upwardly rotate their scapula. So this is a basic sternal lift exercise. We're working in the sagittal plane. So in this picture, Lauren is overemphasizing forward shoulders, and then we're reversing it. Whether the arms are bent or straight is up to individual preferences, but you can see good scapular retraction and good cervical position here. This is an exercise I do for a couple of different reasons. So the main reason for this presentation is for the second part. So getting people into this forward position and then getting them back out of it. So reversing the position to achieve good scapular retraction is the key. Getting good extension. I'd like her head to be up more, but we were watching for scapular motion that facilitates retraction without substitution of upper traps or lats. So I use my hands a lot. Now, the other exercise, obviously, this is similar to gaining forward elevation. So this is called a forward bow when we're doing it to gain motion. But for scapular exercises, it's sort of the second part. This is probably one of the more famous exercises that we developed at the Lexington Clinic. It's called the lawn mower. It's emphasizing the transverse plane and to get scapular retraction with trunk rotation. Here you can see she doesn't have much trunk. Here you can see they're substituting with the upper trap. Now, if they have biceps tendonitis, I found that if the if the forearm starts to externally rotate, notice he's staying in the sagittal plane, that can irritate a biceps. So elbows in the back pocket, same side, is really where we try to get posterior tilt, but the lats can overactivate. So you got to palpate and make sure it's a scapular exercise, not that. So here's a little video. This is Chris. Hopefully this video will play. Chris is the head technician at the Lexington Clinic for many years. He's since moved on, but you can see he's instructed this exercise 7,000 times. He's a weightlifter himself. But you can see it's not just, it's trunk rotation, upright, straight position, not hyperextension, but vertical position. So all kinds of modifications with those exercises can be done to help facilitate the lawnmower. Here we're adding in the hip. So we got some hip core weakness. Now we're going to add some hip extension and stability. All right, I'm going to stop there. I think that's probably long enough video to give you an idea, and hopefully that explains it. Again, I apologize, Dr. Carper, for not being there personally. Hope this helps.